Try, it won't work.
Greetings and welcome to our forum today. My name is Wayne Jennings and I'm the host for today's discussion titled Racism, Healthcare Inequities, and the Future. Given this subject, we hope to challenge you with new information about healthcare inequities that you'll continue to think about and share with others. We hope that some type of community action or healthcare evaluation might take place in the future due to this forum discussion. As Unitarian Universalists, we organize these forums as a congregational service to the community to support personal reflection, social action, and to encourage individual and collective growth for all who attend. Today's forum will be our last one until January 17th when we start our winter forum season. I'd now like to introduce the coordinator for today's forum, Dr. Jim Boyle, a physician at St. Vincent Charity Medical Care Center and a member of our forum committee. He will introduce the topic and the speaker. Jim?
Greetings. We chose today's topic for discussion because of the inequities in the healthcare system are an extremely important topic to all of us, especially in these COVID-19 days. African Americans and Latino Americans have lower rates of insurance, a high prevalence of chronic disease, and a lower life expectancy. Other challenges include access to physicians, financial support from government health-oriented programs, and the cost of prescription drugs. What progressive healthcare actions might we see in the near future, locally, statewide, or beyond? We definitely need healthcare commitment, resources, and remediation for the underserved community in Cleveland and beyond. I will now introduce this morning's forum speaker, Dr. Gregory Hall. He is a leader in urban healthcare with significant experience as a practitioner, physician, educator, and administrator. Dr. Hall is an internal medicine physician affiliated with many hospitals in the Cleveland area and the medical director for 5 nursing homes. He's a director of the Cleveland State University Partnerships for Urban Health, an assistant professor of the Case Western Reserve University School of Medicine, former chair of the Ohio Commission on Minority Health, and a member of the Cuyahoga County Board of Health. Dr. Hall, take it away.
Thanks a lot, Jim. I appreciate the invitation. I am happy to talk about, starting off talking about the COVID-19 and sort of how that relates to the more global picture. We've been seeing issues with too many African Americans sort of dying from COVID-19. And like you say, a lot of Latinx of the population has the highest incidence of cases. And so we've been seeing this and wondering, what is that and what are the dynamics? And so we're going to spend some time talking about that, and we're happy to take your questions as like those will be organized, and we'll sort of do that. This is the most recent. I got this morning. Most recent cases by ethnicity, and you can see that Hispanic Latinos at the top 25% of the cases. And so when you talk about health disparities, well, you really are thinking about, what's a disparity between what it should be versus what it is. And so 16% of the US population are Hispanic Latino. And so we've got 25% of the cases. So that extra 9% is the disparity. It's higher than it should be. We've got you below that, you see Native American, Asian, non-Hispanic. So 4.5% of United States citizens are Asian, and we've got a 3%. So we've got a low disparity there. It's less likely for an Asian non-Hispanic to get the COVID infection compared to the expected population. Next, African Americans, Black, 15%. So 13% of the U.S. population is African American, and so 15% cases is 2% higher. We see whites have now half the cases, and then sort of 4% there. So those are the cases. And then if we look at deaths, Hispanic Latino, 15% of the deaths compared to 16%, so a little bit lower. Asian, not to skip over Native American, a little bit higher, right? Asians are just about, as you would expect with the population. And then with Blacks, 19.2. So then again, that's higher than the 13%. So it goes from 13%, so that's a 6% higher. And then whites, 55%, they're then lower than the total population. So we've got that disparity. Now, if you look at just for cases by age group, you see the 18 to 29% group, that's a quarter of all the people infected. 30 to 39, you see 40 to 49, 50 to 64, that's my age group, 20%. And then as it goes down for each next group, 65 to 74, 75 to 84, it goes down. So 65 to 84, you have a 7% of the population. 75 to 84, 4.2. I know that's small for some people to see. And then greater than 85 is 2.7%. And so who's getting infected is by far the people that are youngest, not youngest, but in that 18 to 29%, the most sort of mobile group. But then if we again look at deaths by age group, it literally goes up by age. And so you see a very low 0.5% deaths among that 18 to 29%. And it just steadily goes up. And in my age range, 15% death rate, and then 65 to 75, 20%, 75, 85, 26%, and greater than 85, almost a third of those people will die. So that's a significant why older people need to be particularly vigilant about avoiding getting it, because again, and if you do, the odds are not, they're not in your favor. This is most recent. Again, I got this morning. The most recent information as it relates to by race and ethnicity, highest death rates. And again, that green, top green is African American. The yellow below that is indigenous, which is Native Americans, and Native Alaskans are neatly behind that. Lower than that is Latinos, and the black line with the red round dots is white, and then below that is Asian. And so the death tolls is kind of what we've been seeing, but overall, if you look at it, the death tolls are still going up. So when you look at the rates per 100,000, and physicians, do this, we are always looking at the rates per 100,000. So African Americans, 814 deaths per 100,000, Native Americans 108, Latinos 78, Pacific Islanders 76, and it should be noted that sometimes we group together Asian Pacific Islanders as one, we being like the CDC and people that kind of track things as one, but we're seeing a different outcomes. Pacific Islanders having a higher incidence of bad outcomes compared to Asians. And so in this case, they sort of teased out Pacific Islanders because they were seeing a different sort of lay of the land. And so they were at 76, white Americans, 62 deaths per 100,000, and then Asian Americans, 48 deaths per 100,000. And so what does that mean? I mean, sometimes it's hard unless you're in the public health world. It's kind of hard to figure out what that is. And so they did, if everyone sort of died at the rate at white Americans died, there'd be 21,000 Black people that would still be alive, 10,000 Latinos, 1,000 Native Americans, and 70 Pacific Islanders that would still be alive. And so that's, that who knows who that would be amongst the people that have died. And this is a real busy small slide, but this just shows cancer death rates. And, if you look, and I'll just read it for you, the lung cancer death rate for a Black patient is 63.9, like 64 per 100,000. For whites, the lung cancer, which is the highest, 54. So, as excited, this is for males, and then for females, the highest is lung cancer at Black females for 33 and white females for 37. So the excitement we go over, try to get people to stop smoking, to get people to to do that. The excitement over lung cancer, you know, the smoking cessation national interventions that we've done because of the death rates related to lung cancer, the things we do for, you know, for trying to screen for prostate cancer in African-American males, that's basically 40 40 deaths per 100,000. Things we do for breast cancer in African-American women, that's 29 per 100,000. So if you have, the things we're doing already, again, take lung cancer at 63 per 100,000, you can see that that's compared to African Americans at 114 deaths. I mean, even white Americans at 62 deaths, that's higher than the lung cancer death rate, right? So, you know, some people are saying COVID, 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 but here we have something that's higher, you know, the death rate is higher for than for lung cancer or breast cancer or prostate cancer, all the things that we were excited about, really excited about before COVID came along. So this is not overblown. This is not exaggerated. You know, these are the facts. And so this is Ohio's trend reported to the CDC. Right now, this goes through November 20th. And so, you know, when we were all excited back in May, right? And then look at us now compared to May. I mean, this is no joke, right? And so it's not showing any indication that it's going to go down anytime soon. I'm looking at your local data. You'll see the Cuyahoga County our county data is also doing the same thing. It's kind of going up. It undulates up and down, but you know, we're still in the middle of a surge that's really not showing any abatement, and we've got some really social times coming up now. These are the cases by zip code. Again, this through November 14th, but it's the latest data. I just got this yesterday. I'm in 44143 up in the right-hand corner. You guys, a lot of you are in 44120, 122, and you can see you're in an area that's a little darker. The darker, the higher number of cases, the lighter, the lower number of cases. Just so you know, when you go to the grocery store, or if you any kind of contacts you have in areas that are particularly high, you know, or if you come from those areas, you're at a higher risk as well. We think about the testing positivity, you know, there's word that, you know, the more tests you do, the more positives you have. But we've always talked about the percent of the tests that we did that were positive, right? And so we were able to get below 5%, which allowed us to, you know, try to really, you know, encourage schools to open, for example, and, you know, to try to lighten up some of the restrictions that were killing some of the economy. But now look at the positivity going from October 9.3%, November 14.9%. Now we're at 20%. So we were trying to get below 5, and you know, red lights and horns were going to go off if we got above 10, and now we're at 20.5. And so we're seeing a huge positivity rate because the number of infections is going up, not because we've been testing pretty well. Now we don't have the capacity to test because there's so many people to you know, to test, and it's been difficult to get those people into a situation where they can get tested, basically. In the nursing home, testing positivity is at 10%, which is also a significant issue. Just to kind of round out some demographics for those of you who like that type of stuff, it's still, there are females more apt to get cases than males, 55 to 45. I showed you, excuse me, the age groups, 20 to 29 still being the highest. Whites obviously still the highest, but in Cuyahoga County, disproportionately high. Blacks at 28%. And this is the Cuyahoga County data that excludes the city of Cleveland. And so Cuyahoga County has like a 29% African-American population, but a lot of that comes from Cleveland's 51% African-American population. And so Cleveland has its own Department of Health. And so Cuyahoga County kind of covers everything but Cleveland. And so that's, that's the way it is. So this 28 is higher than the percentage of Cuyahoga County African-Americans that exclude the city of Cleveland. Healthcare workers like myself, we have an increased rate of infection as well. And then obviously people with pre-existing conditions have an increased rate. So African-Americans, particularly with diabetes and kidney disease, are at higher risk for a COVID hospitalization. So, but we know, physicians know that coronavirus does not infect, sort of based on race. And so people have asked, is racism the cause for this kind of disproportionately high impact in the African-American population? And more importantly, a lot of communities are asking themselves, is racism a public health crisis, right? And there are some, City of Cleveland declared racism a public health crisis. The county has declared racism a public health crisis. And so what sort of drives that? Okay, so some of it is a little historical perspective. Many of you probably heard of the Tuskegee syphilis study. Went from 1932 to 1972, but it was organized by the U.S. Public Health Service. It wasn't some independent university, or it was it was the United States government deciding to study the natural progression of untreated syphilis in rural African-American men in Alabama. It was well designed at the time, 600 men, almost 400 with and 200 without. They were going to compare the people with it, did without. It was relatively reasonable because in 1932, because there's a lot of just sort of ragtag approaches to treating it, and none of them resulted in a cure. And so, it was a reasonable approach when it started. It sort of, I show this to the people at the Board of Health because, if some people in the Board of Health say, we'll go to some houses and they don't let us in, or they don't answer the phone. And so it's important to see that these flyers that went out were particularly aimed toward colored people, as you could see, African Americans. Excuse me a second. And they said that they were it was sponsored by the county health department and government doctors. So it was a way to say, this is safe. You can trust us. Come on, come all, right? And it was fine until 1942, 10 years later, when penicillin became available and was finally in stock. And then somebody made the crazy decision to not end the study, but to keep it going, even though there was a cure for syphilis at that 10 years in. And so what that entailed telling all of the physicians, who would then tell all the receptionists and all the medical assistants and all the nurses who were the men that were in this study. And if they happen to accidentally show up to your office for care for one thing or another, don't treat them with the penicillin because they're in a study. You can treat their wives, you can treat anyone associated with them, but you can't treat them because they're in this government study. And so that's where, people worry about, that's sharing information across in a wide range of areas so that when, Mark Johnson walked in to a doctor's office or an ER or an urgent care, well, they didn't have urgent care, but in the, they'd find him on there and say, oh, tell the doctor, well, don't treat him. But if his wife comes, treat her. I mean, it's just crazy. So that dissemination of private information, actively not treating someone that has a disease that has a cure. And so, 10 years into this thing, that's how it went. And so until a New York Times article, which, came out in 1972, actually halted it. And so, and then, they sort of reviewed and then decided that they would end it. So that for another 30 years, they actively avoided treating these men. And so you wonder, that happened a long time ago. There was a study by Johns Hopkins that asked about the awareness of that and found 81% of African Americans were aware the study and its outcomes, where only 28% of whites had any knowledge. And so that sort of thing is, it's a stain on the medical care, on public health, as we talked about the trust in vaccines and things like that. And so that's an issue. More recently, J. Marion Sims, the father of gynecology, they've been looking at his statutes, looking at statutes. And then, so it turns out, meticulous surgeon and meticulous documenter. He documented everything. He did experimental surgeries on unanesthetized slave girls over and over again, and documented who he did the surgery on, what surgery he did, whether it worked or not. He was acclaimed in Europe and in the United States for his, him sticking to scientific protocols and whatnot. But the thought of torturing slave girls in the name of science, it wasn't against the law at the time, some people have said, but it was still terrible, and it should have been against conscience. And so that's coming up more. And then, I never thought about, how they got cadavers before. People, now people give their bodies to science. And when I was in medical school, we had every year we had 50 cadavers to learn anatomy on. But I never thought about how did you get cadavers back in the old days, right? And it turns out that they went to potter's field, people that were poor or homeless, and more reliably were Black cemeteries. You could steal a body from a Black cemetery, and apparently the authorities wouldn't do much about that. And so there's been more and more articles about grave robbing that really was a significant impact over the years. And when they recovered bodies, they would see they were obviously part of surgeries that were done post-mortem. And so, but in Black communities in the South, in urban areas, imagine, having your husband or wife pass, or your child or your mother or father, and you have a funeral, and then a week later you go to visit the remains, and it's been dug up and stolen, and who it is. You don't wonder. It was a medical school in the next town, and one of the medical students, many times were the ones that were tasked to go and get their bodies if they're going to learn about it. And so this was something that apparently was widespread. I mean, and families knew, and they talk about it, and so they don't trust, don't trust doctors that used to be medical students. You were the person who stole my grandfather's body, or these things are out there, and so it's important to know. And then they talk about, this article was about Grandison Harris, who was a grave robber that was initially enslaved and later employed by the Georgia Medical College. And so you see this picture, and then there's Grandison Harris, and there's no other reason for this gentleman to be in a Georgia Medical College graduation picture unless he was critical to their education. And so who's best to go to a Black cemetery to steal a Black body? A Black man, right? I think that you can slip in a little unnoticed rather than others. And so this was a thing, right? And then more recently, I saw this is one of the first heart transplants done in Virginia. And there's a book I show you that was written about it, that talks about a 53-year-old Richmond man who fell off of a 3-foot wall. I mean, so that's a yard, right? He fell off of a 3-foot wall and hit his head, and was declared brain dead within 24 hours. And they took his heart and transplanted it. It was the first successful transplant. This was done in the 60s. And, they couldn't find his family, even though he had a family, extensive family. And, if you just it's just amazing, the things that, the array of things that they did in order to get this done. And, people in the hospital know it's nearly impossible to have someone declared brain dead within 24 hours, to not do your due diligence in terms of finding a family member, all they just, so this is these are things that's sort of kind of, it's okay to talk about now that is further away. And people are saying, you know, this truth is going to be exposed. But these are the things that within the Black community, they knew about it. This man's family knew that this happened. His friends knew, his coworkers knew that this happened. And so that sort of, it's a stain on, you know, on the medical, you know, world. And so, you know, medical science in the United States, sort of advancements in science depended on poor and Black bodies in order to sort of advance the quality of care for other people, frankly. And so, you know, that's sort of our history. And, you know, it's sometimes hard to live that down. You guys are also probably well aware of redlining, which we looked in Cleveland, a relationship to health equity. The Quiron Institute at Ohio State sort of looked at how redlining was done. And redlining is where you literally take a map and you draw around the street boundaries and say, once you've outlined sort of a street boundary, excuse me again, you determine that we're going to divest in this areas. We're not going to grant loans. We're not going to refinance houses. We're not going to bring industry. We're not going to do anything. This is an area that is sine qua non, you know, right? So, you know, redlining was designed to disenfranchise in the community, and it was done, based on race, right? And where minorities lived. This happened also in Baltimore, where it said, you know, Blacks should be quarantined and isolated, you know, in order to reduce the incidence of civil disturbance, to prevent the spread of communicable diseases, which they felt were more prevalent in Blacks, and to keep them out of nearby white neighborhoods where you could kind of refinance your houses. And so this racial driven zoning was done by the government, again, endorsed by the mayor, endorsed by banks, endorsed by the Federal Reserve. And so these, you know, these things, your house value went down if you were in a redlined area. And so, and this was all done, like not all done, but done saying, you know, we need to prevent communicable, they have diseases that they're going to bring to you. So this is really done in the public trust, right? And Boston as well. I mean, issues related to that. And so that redlining led to disinvestment, to housing decline, to predatory lending, property value loss, and then those foreclosure leads to crime and safety problems, increased poor education, asset loss. You know, you can't refinance, you can't pass a home down to your children that has any kind of value that they could kind of grow or make another loan on for their next family. So that redlining, you know, really impacted the communities and really brought us to some of the disenfranchised communities we have now. And so this all leads to, when you ask people, and this was, it's in our Harris's textbook of medicine, one of the co-authors is Fauci, you can see there. And so this, you know, Dr. Fauci is not just a, you know, fly by night. He wrote almost a textbook for internal medicine, but it asks you, have you been treated unfairly by healthcare workers? And if we look at, have you been treated unfairly in the past, 15% of whites say they have, 35% of Blacks, 36% of Hispanic Latinos say they've been treated unfairly in the past. And then the next question was, would you expect to be treated unfairly in the future? Right? So 22% of whites expect to be treated unfairly by healthcare workers in the future, compared to 65% of Blacks and 58% of Latinx. So you've got a population there that's actually looking for you to treat them unfairly. I had 2 patients that were in the ER at St. Vincent's, and I went down to see them. I saw the one, then I went across the hall and saw the other one. And she asked me, she says, I haven't had anything to eat. Can you get me some ginger ale or crackers or something? So I said, sure. So I went to the nurse, got a ginger ale, some crackers, went back and took it to her. My patient across the hall looked at me and waved at me and said, you know, why'd you give her ginger ale. You didn't give me ginger ale. So I was treating her unfairly because she was looking for it, right? And I'm saying, you didn't ask me for any ginger ale. I got it for you. I wasn't treating her better than I was treating you. I was just accommodating her request, but she saw it as me treating one person better than the other person. And so even something like that, I'm now mindful of, if I go get one person something and the other person, let me get that person too. Probably if you have kids, almost you have to do that. But this is the lay of the land that we're sort of in. And so what helps with building trust with a population like that? Racial concordance. And so having programs that support bringing the next generation of African American and Latino physicians so they can treat, because African Americans disproportionately, almost like 75% treat African American population. So it's like that's my practice is 85% African American, and I'm not designed to do that, but that's just how it works out, right? And that racial concordance allows me to, I can build trust. I still have to do it. I don't get the trust de novo, but I can build trust faster than equivalent white physician or Asian physician. And that trust can be built. I mean, we know Jim Boyle has a ton of loyal patients, right? And so that it can happen. It's not hopeless. It just takes a little bit more time. And sometimes you may not have those extra, you won't have the time to get them under control. Racial concordance of physician extenders also help. So again, I have residents from St. Vincent's rotating in my office, and I had a Eastern European patient, Eastern European patient, been coming to me for a couple of years. Nice guy, but to the point, never smiled much. He would do exactly what I asked him to do, a great patient, but we didn't have a warm relationship. And I had an Eastern European resident come, and I sent her in and saw him, and they were from the same country, the same city. They were in there for 45 minutes. They bonded, they smiled, he smiled. And after that visit, he sent his wife, because I was open to Eastern European people at that point. And he saw me in a totally different way, all because the hospital randomly sent me a resident, right, that happened to be from the same town. But that was a physician extender that made me look better. It made him feel better about me. And so it's not just something with African Americans. And so as much as we can have people that you feel like you have something in common with, that helps significantly, because having that trust increases your rate of your patient's self-rated health, their therapeutic response, their adherence to taking their medicine every day. And that of course all leads to decreased cost of care. And so a patient's adherence to referrals, preventative screenings, all these things is tied now, we can tie to their trust for their provider, right? And so we saw a study back in 2006 looking at racial concordance and found that African Americans were, compared to whites, were most likely to report low trust in their healthcare providers. So you have that low trust. That's why they don't, I have patients come to me and I don't like doctors, I don't like medicine, I don't like, and that's disproportionately high. And they also found, another study found there was elevated concerns particularly among African Americans about personal privacy and potential for harmful experimentation. So then there goes the Tuskegee study. And so when I say, your blood pressure's high, let's try amlodipine. They're like, try amlodipine? What do you mean? Don't you know if it's going to work? And it's like, well, no, I have to see if it works in you. We're not just trying it. So it's a thing where you have to kind of explain it. I'm not experimenting with you. We're just going to see if this works in you. But there are issues with people thinking that we still are sharing information. And I tell people, even between husbands and wives, I don't share information, much less sharing it with other people and with issues of personal privacy. So is racism a public health crisis? Now, with all that in mind, yes, it is, because that's what's set up. That's what redlining set up. That's what these experimentation studies set up. That's what all these things that were sort of sanctioned, being able to have you can't grave rob white cemeteries, but you can grave rob Black cemeteries. That set that up. That was a decision the public made, the public, public services made. So all these things sort of set those things up. And we know that viruses follow a similar path of infection. Your increased risk factors for coronavirus: living in crowded housing, working in essential services, inconsistent access to healthcare, chronic health conditions that are poorly controlled, high stress that leads to poor immunity. And so those are risk factors, as well as or being exposed to people like that, living in crowded housing conditions, being exposed to people that work in essential services or that have inconsistent access to healthcare or that have chronic health conditions that are poorly controlled. And so doctors like myself, or Jim Boyle, or people that work that are people in churches and like this, that are you're trying to have an outreach to everyone. You're not trying to discriminate, but that increased exposure to people that have that also puts you at increased risk for infection. And so poor education, high crime, crowded living, no or poor insurance, that all leads to low paying jobs, increased chronic diseases, and that leads to health disparities. So I want you to take a minute and look at this and assign my one test question for you. I want you to assign the life expectancy for this. I mean, who's number one? A life expectancy of 74.8. This is men and women combined. And who is life expectancy of 78.5? Who has life expectancy of 81.8? And who has a life expectancy of 86.5? Is it African Americans, Asian Pacific Islanders, white Americans, Hispanic Latino Americans? Who's one, who's two, who's three, and who's four? So if you could just mentally sort of assign those to yourself, what racial ethnic group has one, which one has two, which one has three, and which one has four? Okay, that's the answer. So when I was appointed to the Ohio Commission on Minority Health back in 2002, I will admit that I thought minorities had poor life expectancy and the majority had a good life expectancy. So if I were choosing this, I would have chose your African American 74.8, because again, most of my people in the Hall family died about in there. I would have chosen probably Hispanic Latinos to be 78, and I would have chose probably Asian Pacific Islanders to be 81, and I would have chose white Americans to be 86. That's what I would have chose, just thinking about minorities. And I would have been wrong. I don't know how many of you might have made those same sort of assessments. And so it was surprising to me to see that Asian Pacific Islanders live 12 years longer than African Americans, and Hispanic Latinos live way longer than whites, for that matter. And I wrote a book on patient-centered clinical care for African Americans, and as it was getting rejected early on, they wanted me to write about other minorities. They said my writing was fine, I need to write about minorities. And I think the problems with minorities are not the same, right? For Hispanic, Latino Americans, a lot of their health disparities are driven by access to care and language, right? Communication. And there's just a world of difference in that. And so I insisted that African Americans needed a significantly different approach because of the grave robbing, the things that I've talked about. And so it's important to sort of know that when you look at life expectancy by race, African Americans have always sort of been outliers, and we see we made significant improvements. I mean, look at how high the mortality has we've increased for Blacks. Back in 1970 it was about 60, life expectancy of about 63, if you can imagine, and now that's up into the 70s. But there's and it's been a steady improvement, but that disparity is there. And then you again compare. This is the age-adjusted death rate for people 25 and older. We see the death rate is highest for non-Hispanic Blacks, next for whites, and then you see how much lower it is for Hispanics. Now, if we look at the age range from 25 to 44, since 2012 or so, it's starting to go up for that age group, 25 to 44, and some of that is these unintentional injuries or poisons. Those are opioid overdoses that are unintentional. Taking a selfie right outside of the Grand Canyon and things of that nature, increased suicide and increased homicide in that age range. And so looking at persons 45 to 64, leveling off, but still a little bit of an increase amongst all those age groups, particularly. But you see the disparity, again, much higher for Blacks than whites and lower for Hispanic Latinos. But once 65 and older, you can see much less of a disparity between Blacks and whites, but then Hispanic Latinos much lower in their death rate. And so if you look at the mortality rate on this table, it's just looking by race. You see the highest one on the far left, the African-American males like myself. Next to that in gray, African-American females, and then there was whites, all races together, Native American men and women, Hispanic, Latino men and women, and then Asian Pacific Islander men and women. So again, I was raised to believe that men live longer than women, right? That's what I sort of was raised to believe. But if you look, African-American women don't live as long as Native American men, Hispanic Latino men, or Asian Pacific Islander men. And so that's a curious occurrence that sort of goes against almost nature, right? And so if you look at what contributes to the decrease life expectancy in African Americans compared to whites, we see heart disease is the major driver of that. That's what takes away life. And then cancer and homicide, diabetes, those all make a difference. And so African Americans have the worst outcomes for cardiovascular disease, 321 per 100,000, way higher than the 245 that are in whites, and so on. The highest for diabetes outcomes, and then the worst outcomes for cancer, for lung, breast, ovarian, cervical, colon, prostate, pancreatic, liver. You see it, the worst. And so in the cross for cardiovascular disease, it just says that African Americans have had the worst outcomes, increased risk for hypertension, increased risk for heart disease, heart failure, 3 to 4-fold increased risk for stroke. And, and African Americans at age 45 have a 5 times as likely to experience an intracerebral hemorrhage. And so that's 5 times, right? And that's all driven by hypertension. 90% of those hemorrhagic strokes are driven by hypertension. And so I think that, most prominent in my mind is Stephanie Tubbs Jones. She passed from a cerebral hemorrhage. That's public knowledge. I don't know whether she had hypertension, but there's a 90% chance that was the case. And so, and at a youngish age, so it's important to know. And then African Americans are more likely to experience a sudden cardiac related death. And so thinking about hypertension, this is just a study, I'm not trying to beat you over the head with it, but this study showed that 75% of Black men and 75% of Black women have hypertension by the age of 55. So that's 2/3 of every, 3 out of 4 Black people over 55 have hypertension, compared to 55% of white males and 40% of white females. And so that's a lot of people. And the other really stunning information that came out of this study that showed that Black men, if you look at that top orange solid line, or if that's orange, I don't know what that is. Looking at that line, look at the percentage of Black men under 30 that have hypertension. Almost 30% of Black men under 30 have hypertension. So you see someone 26, 27 like I do, and their blood pressure is 150 over 88, and you blow it off because they're young, they're probably just excited or whatever. That's hypertension. And compare that to white women, that Black hashed line, 30%. Look how low that is, at age 30. And so this is stunning that this increased hypertension, and it's not, it's not sort of being addressed. And their conclusion, given that racial differences in hypertension emerged before 30 years of age, primordial prevention, we've got to start thinking about being more aggressive about treating people that are younger.
So Dr. Hall, this has been a wonderful presentation. I think it's time for the audience to have a chance to ask some questions. So I think we'll just hold off right now for the more data. And I'm going to have Debbie and Laura present you with the questions from the audience.
Okay.
I was kind of interested in that question about hypertension, but okay. I'll ask the questions on my list here. How do we, and a great presentation so far, thank you. How do we change the African-American community's perception of and experience in the healthcare system with health and medical workers regarding medicine and healthcare? Lots of complicity within the system. And then she says, blah, blah, blah. That's way too many words. How do we solve this very real problem and barrier to healthcare?
Well, I think we have to start showing that sort of Black Lives Matter. I mean, there are things that we continue to see where we're kind of African Americans are marginalized in different environments in the healthcare center still. What I was going to show, particularly with those studies, is that 20 years ago, it turned out that that the best treatment for hypertension was calcium channel blocker and a hydrochlorothiazide, a water pill, right? And that it was not well treated by an ACE inhibitor or a beta blocker, right? ACE inhibitor like lisinopril or a beta blocker like metoprolol, right? And so, but since that, there was a study that done since then that showed that a third of African Americans are still being treated inappropriately with the medicines that are best practice for white people. And so providers are applying best practices for white people onto African Americans. The indication for colon cancer screening is age 45, not 50, right? But everyone thinks that you're supposed to get a colonoscopy starting at age 50, but for African Americans, it's actually 45. And that was proclaimed in 2005 by the American College of Gastroenterology. And so you have these specific recommendations for a community that are still being ignored by some providers that have patients in their population by following these majority recommendations. And so, when we see health disparities, that there are problems in this group, and then we know that we have recommendations that have been agreed upon, yet they're not being ignored. They're just not aware of them, right?
I think they might be being ignored. It's like herding cats to get providers to follow the rules, isn't it? Yeah. So, but I don't know how you change that.
Well, we have to hold them accountable. I think that's what you do. I mean, and then, many times my patients will hold me accountable. Am I due for this, doc? Am I due for that? I think so. Maybe an opportunity like this for someone to say, I'm on lisinopril for my blood pressure alone. Now, if you have diabetes or if you have kidney disease, you're supposed to be on lisinopril. But if you just have hypertension, you shouldn't be on lisinopril alone for that. You shouldn't be on a beta blocker alone for that. If you're African American, because the data shows that it doesn't control your blood pressure, and there's worse outcomes associated with that. And so if you can kind of go to your doctor and say, hey, I don't think I'm supposed to be doing on this, if they check, they'll see. And I teach the class on hypertension at NeoMed, and so this is what we're teaching medical students. African Americans, we learn about different screening measures for Ashkenazi Jews. You're supposed to be more aggressive with breast cancer screening, really more aggressive with colon cancer if someone's an Ashkenazi Jew. That's just a fact. There's certain medications that don't work well in that population. And so it's not racial profiling, it's just patient-centered care.
Are there alternative ways of educating people, such as churches or places like that, where they maybe will listen and help educate their doctors?
Yeah, I think so. And I think, things such as this, I have a best practices sort of thing that was just released by Pri-Med. I do a monthly lecture to physicians across the country on the best practices in the treatment of African Americans. And I just posted that on my Twitter account. So if someone wants to, I'm at Dr. Greg Hall. They can go and see that, and it has a link to my lectures, which is for providers. But sometimes people like, my patients like reading, listening to articles like that are for doctors, and a lot of times you can get through it. It's not that high end.
Dr. Hall, I have 3 questions for you that all have to do with trust in the medical profession and medical providers. So the first one comes to us from Eileen Bale. She asked, is there an age lifestyle factor having to do with trust in healthcare system? For instance, are certain age ranges in the United States more likely to be trusting or not trusting than others? What about lifestyle? Are people with certain kinds of lifestyle more likely to be trusting or not trusting? That's the first question.
Okay, well, thanks for that question. Well, there's no particular data that I've seen that breaks that down. I've been a doctor for 25 years. And so I find it's amazingly spans the ages, so it's certainly not going down amongst my younger patients. Like you would think, well, the older patients that were more around the Tuskegee thing would be more distrusting. They've seen more grave robbing, and the younger people don't. But I don't know what's making it persistent. There's no data that shows what you're asking. I see it across socioeconomic status, and so I've got some people that make a lot of money that don't trust me or medicine, and I've got people who make very little money that don't trust me or medicine. So I've seen it across. And I've got people, so it said 45% of African Americans. So there's 55% trust fine. I mean, so I use my family, for example, my mother's side of the family, my grandmother, I told my grandmother I was going to be a doctor, and she said, that was her response. She was not happy, right? And my father's side of the family had multiple doctors already, and so that was sort of expected on the Hall side. So they're even within, she didn't go in to tell me about anything, any atrocity. Well, I mean, she did, but she said, since I touched on it, she went to the doctor with a sore throat. He looked in her mouth and saw that she had a tonsillitis, and he grabbed forceps, reached in her mouth and ripped her tonsil out. And then she's traumatized, and then they actually got on the floor, and he reached in and ripped her other tonsil out. And so that's how she had her tonsillectomy. And so she said whenever she would see someone on TV in the hospital eating ice cream, waking up after a tonsillectomy, she would get mad again and think about that's how her tonsils were taken out.
My throat's kind of hurting.
Yeah. Well, that's what they did. So that was the one story my grandmother told me. So maybe that's all she needed to know about doctors. But
do you see a distinction between trustful attitudes in men and women?
I don't. I mean, I see about half seas, half and half. I think men may be a little bit more resistant than women, but I haven't compiled it specifically. But it runs across both, I think.
Do you think that the African American churches can be helpful in building trust in the medical community and medical practitioners?
It's sort of like reaching around something. I mean, I really think, I think they can be helpful, but I think that, the doctors, it's like, can someone else tell me to trust you faster than you can get me to trust you? I think you can get me to trust you much faster than, all my friends saying, I don't like so-and-so, I like so-and-so, even though I don't like them. You know what I mean? And so it's like, I think the medical provider should take primary responsibility. The medical establishment should take primary responsibility in earning the trust the people they want them to trust, right? And then, I think then other organizations kind of help sort of rectify that, right? And so if I say, I think I like Laura, and then Debbie can say, yeah, she's really a nice person. That's that's different than like, I don't know about Laura. And then Debbie says, well, I think she's a nice person. Well, I'm still only halfway there, right? I'm still going with my gut. So I think it's important that the medical establishment makes it a priority. And doctors don't know. A lot of doctors don't know about this. I didn't know about the decreased trust. So it's important that we kind of get information out to them. And that's what a lot of my lectures are doing, nationally, just letting people know about the lack of trust. They think if you come from a community that just loves doctors and admires them for their intelligence and their dedication, spending so many years learning to be a doctor, and you just think we're just wonderful, then you wouldn't imagine that there would be a large group of people that think that they're really not wonderful at all. You know what I'm saying? And so, but that's where a lot of people come from.
Right. Yeah. One thing I was thinking, you were talking about doctors not knowing, some doctors go to medical school and think they're done learning. They became a doctor. I'm a doctor, that's it. Whereas medicine's changing all the time. And, nowadays, I think, don't you have to take a relicensing exam every so many years? And maybe we need to influence these relicensing exams to put this new data in there and, and center it that this the differences in how you may treat hypertension in one population versus another. And that's maybe where your politicizing needs to go.
Well, you know what? I'll tell you about licensing exams and standardized exams are incredibly biased against the African American community, and so there are a decreased number of African American providers for African Americans because of standardized exams, and so I would never encourage anything that would require a standardized exam because they're incredibly biased, and so I understand what you're saying, but there needs to be, I think physicians know they need to keep up on things because things are changing all the time. And like, again, I had data on these slides that was from 2 weeks ago, and I just decided at the last minute to update it to this morning, and it was different, right? And so the indications for the best treatments for the coronavirus have changed over the last month, right? The way things that we're doing, 2 months ago is different from the way we're doing them now, right? Because we're just learning as we go about what to do. We're kind of getting out of the dark, it's shady, but in terms of the treatment. So, I think there's, people are making requirements to people to, I had over 1,000 doctors on my thing last week. So doctors want to do better. We're good-hearted people, and we want to do better. And we're now being held accountable for our outcomes through our NPI number individually. So how well do we control diabetes? How well do we control hypertension? So I think doctors are now financially sort of motivated to stay up on things, because if our patient outcomes don't improve, then we're going to be dinged with our reimbursement.
Right. Well, one other question. This is from Lori. It seems to me that increased blood pressure among Blacks could be attributed to systemic racism and microaggressions throughout daily life. Is there validity to this hypothesis?
Yes, yes, it is. There is, and there are people that think that racism itself, it causes. Well, one theory is that it causes increase in stress. Stress is the fight or flight, right? And that's when, like, a lion comes in the room, your blood pressure goes up so you can run, so it can deliver blood to your muscles so you can flight, right? Or fight or whatever. And so that increased blood pressure is functional. But if you are in the area where the sirens are going down the street, or you hear gunshots outside, or you're worried about your kids and all those things, all that stress leads to an increase in cortisol that can cause an increase in diabetes, increase in obesity, increase in hypertension. The epinephrine causes an increase in blood pressure. And so some of that may actually be the case, but it doesn't negate the fact that your blood pressure needs to be lower. right? And so if you move to Tahiti and where life is good and you're lying on the beach, your blood pressure is lower, then maybe you don't need blood pressure medicine. But until you move to Tahiti, you need blood pressure medicine, right? And so until there's no racism, you're going to need some blood pressure medicine because that's been shown to decrease the rate of stroke, decrease the rate of heart attacks, you know, hemorrhagic, intercerebral hemorrhages, all those decrease that. And so I try to impress upon my patients that, you know, that's what's important. That's a take home message. I mean, yeah, your life probably is stressful. Mine is too, but right, we have to treat that. My blood pressure went up beginning, I started in about April and May, and I've never had hypertension, but I'm over 55. And I thought maybe I was one out of 4, but, and I'm like, it's probably this pandemic, you know, that's causing my blood pressure to go up. But eventually I just said, well, you know, I need to start medication because it is the pandemic. I'm not going to have a stroke because it's the pandemic. You know what I'm saying? So my blood pressure needs to be lower. So I'll start the medicine.
Great. Pilar, do you have a question?
I do. A question from Jim Rich, and I think it's in the back of all of our minds, Dr. Hall. Do you have any idea when the surge in COVID-19 is going to peak? Do you and your colleagues have any idea of when it will peak in the United States, when it will peak in Ohio?
Well, I don't have any idea, and we're not seeing any evidence of it. You know, every day is a new record, right?
Yeah.
And so how high can it go? But you saw that graph is incredible. And you know, it's really a race against time. And the amazing part is it's all going to depend on if people could just sit still. You know, if everyone could sit still for 14 days, which we couldn't, because people would still need hospitals and food and stuff like that. But I'm just saying hypothetically, if everyone could stay in one place for 14 days, it'd be over. It'd be over on the 15th day, right? You know, other than the people that were still in the hospital, right? But we can't do that. So it's just a matter of us not spreading, you know, to more people. And so, but if as long as, you know, it's hitting rural areas now, there's still a lot of people that are going to travel, you know, this coming week for Thanksgiving to visit friends and family, and that's going to be a lot of traveling in airports, a lot of indoor time. So to expect that it's not going to continue through Thanksgiving and then the aftermath of all that spreading, you know, from Thanksgiving, that's 14 more days. And then what do we have? Now we've got Christmas shopping and Christmas. So
And New Year's.
yes. And so it's, you know, I don't have a crystal ball, but if I was gonna guess, I would guess it's not gonna get better, you know, within the next 6 weeks. I could be wrong. I'm wrong. I've been wrong. You know what I mean? But I can expect it, you know, but I think people are seeing the surge. People are now, almost everyone knows someone who has it, you know, and may or may not know how they got it. And so I think it's, you know, I don't think it's ever, I'll be happy to see the news one day when they say we haven't set a new record. And these new records every day are blowing away the previous records, right?
Yeah.
And that's what we're seeing in Carter County locally. Every day is a new record above the day before. So once we stop hearing that, I think we'll, you know, a surge can't continue forever, but this one is going on quite a while.
It's a helpful answer. Thank you.
Yeah, yeah. Where do you think most people are getting their COVID-19?
Well, it's, you know, I think it's, you know, it's really just around people. You know, I mean, we saw the young people, not to blame them, 18 to 30, but they're the highest group, just looking at statistically, they're the group that has the highest amount of cases. And so, you know, they're the ones that are going to live forever. You know, at least that's how I felt when I was 18 to 30, right? And so recommendations related to washing your hands. They're the group worst at washing their hands, you know what I mean? And all that there. So, you know, I think if you have that in your life, them in your life, that's a risk, right? They're the ones working. I went to the grocery store and I had to touch everything I put into my cart. You know, I wiped my cart off, but then when I put everything on the ramp, the young girl, she touched everything that I bought to scan it, right, and put it in the bags. And then she put it in another cart that was from the last person who touched it. My cart was in this place. So then I had to take that new cart, which got the person before me. You know, have you ever seen them do that switch the cart thing?
It's an Aldi shopper, obviously, yeah.
Yeah. So they switched the cart on me. So I'm thinking, okay, now I got a new cart. This 20-year-old has now touched everything in which she had to, right? With gloves
spread
on.
Through the air, isn't it? Spread through the air more than that touching.
But she had gloves on that she hadn't changed all day, right? So her gloves touched everything that everyone bought early before me and touched everything in my cart. And then I brought it home and touched everything. I'm washing my hands and everything. But, you know, that was $140 at the grocery store. That was a lot of contamination. I was reflecting to myself. So, I mean, you just have to think about, you know, that was just a lot of, you know, so, I mean, that's just one example, but you got to be thinking about it all the time.
So how do you talk to people who don't believe COVID is real?
You know, I'm pretty harsh. I had a younger person who said she didn't wear a mask to the office, and my medical assistant said, you know, you weren't going to be seen without a mask. And she put one on and she told me, I don't believe any of this. Now she's obese. Her blood pressure was like 200 over 110. And she was not even 40, maybe 38 or something like that. And I kind of tore into her. I'm like, you're the one's going to end up in the hospital on a ventilator, and your kids aren't going to have a mother or a father. You know what I mean? And have you thought about who's going to get them? And you know, I really kind of went hard on her, and she started crying. But I was like, you know, and she's a Uber, you know, she's not a Uber, but the food delivery people.
DoorDash.
Yeah, and I'm like, you're not wearing a mask. You don't believe in this. You don't have any alcohol in your car, any hand sanitizer in your car, and you're just, you know, this is not good. You know what I mean? So I think I was able to change her mind, because that was the approach I took with her, because she was taking, I don't believe in all this stuff, yet you're coming to see me. But you know, it's thankfully it's rare in my practice. People have been wearing masks and whatnot. But you know, the data that I showed today is at least trying to say that this is not just a COVID. It's not, you know, and we're not rounding the turn on which we were. And it's not being overdone by the fake news. This is really out here, and it's really something to be feared. And if everyone was on the same page, it didn't have to be this way.
Are there some ways you can think of that would solve the inequities in the healthcare system going forward? One of the people who is asking a question is Susan Alcorn. She has talked a little bit about the Affordable Care Act and the fact that 15 states have not chosen to implement the expansion of it. So that could be one way of helping, and there's others. Can you tell us some ways that you might go about changing inequities in the healthcare system?
Yeah, well, I mean, of course, there needs to be, you know, people need, so in America, right, everyone gets medical care, right? The issues is, you know, people don't die on the street. You know, if you get sick, you go to the hospital treats you, they apply for Medicaid for you. And then once you have the increased issue, you get Medicaid and the hospital gets paid. But it's an inefficient way to do it, right? So when we talk about, you know, is healthcare a right or a privilege, right? America basically believes that healthcare is a right, right? But they sort of believe it's a privilege, right? But they basically, what we actually do is treat it like it's a right, right? Because people aren't dying in the streets. We don't let people die in the streets. We admit them, but they don't. But they get inferior care, and it's inefficient, and it's really, really costly, right? And so then that's when everyone's taxpayer dollars say, you know, is that the smart way to invest in care, or should we be investing in trying to prevent when this person gets to this point, which is far cheaper to prevent someone, to get someone to stop, you know, investing in screening, proper screening for colon cancer before they get colon. You take a polyp out of the colonoscopy, right? That prevents them from getting colon cancer, which is major surgery and chemotherapy and bone metastasis. And you prevented all that with a $200 or $300 colonoscopy, right? So that's far more efficient. But if you don't have that insurance up front, you can't get the colonoscopy, you can't get the mammogram, you know, you can't get the advice to stop smoking or you know, whatever they give you to stop smoking. So I think expanding the Affordable Care Act or expanding whatever you want to have people fundamentally covered so they can get preventative care is going to help us on the back end in terms of saving the amount of money that we spend year after year, increasing the spend year after year on you know, on these things. And so you know, that's critical. And I also think helping to increase the number. You know, right now there's 4% of physicians are African Americans, and it's like 6% are Hispanic Latinos, way below an equitable amount to treat their community, right? And so being deliberate about that, there was an article that came out that said that Black OBGYNs do better at infant mortality, have better infant mortality rates than other races amongst Black women. And so just having that to impact the ton of money that's spent on infant mortality, you know, is. So we've got to be deliberate about opening the doors to minority populations, to you know, to being physicians. And I think that you know, and again to your point earlier about standardized tests, if standardized tests weren't so discriminatory, you know, that would happen. But they are consistently discriminatory and covert, you know, about it. And so, as I've described, you know, the differences in the treatment of hypertension or differences in the interpretation of diabetes, that may not be involved in these exams, you know. And so these things, you know, that needs to be examined. So now they're getting to the point where they're not even using the SAT. Some colleges like Case is going to go test, you know, free without using an SAT or an ACT as criteria, because they know how discriminatory it is to use that. And you're excluding a whole lot of ably minded people from fields that we need them in. And so I think once it's kind of inclusion, having people in the room that can kind of bring these points up is critically important.
How about the cost of medical school?
Dr. Hall, for an excellent presentation.
Oh.
This very important topic of racism, healthcare inequities in the future. We truly appreciate Dr. Hall's expertise, experience, and commitment to being here with us this morning. Since this is the last forum until January 17th, stay tuned. We have important announcements to share with you. Please give us your suggestions for upcoming winter forums and speakers, and put your suggestions in the chat box. We look forward to hearing your ideas for forums on current newsworthy topics that will attract a wide interest next year. If you have other general thoughts or suggestions for our forums, also put those in the chat box. This forum has been recorded and it will soon be available on our Unitarian website, uucleveland.org. Look for the recording of today's forum starting tomorrow in the large forum square of the website. You can also find it by clicking on the small YouTube button in the upper right hand side of the website. We want to invite all of you who to attend our Unitarian service, if you care to, at 11 this morning. The service will be conducted via YouTube, and to participate, go to uucleveland.org and click on the box in the upper right-hand side of the website. The YouTube link will take you to the service where you can participate in all aspects of the service. We look forward to receiving your ideas for forum subjects and speakers via the chat box. Thank you for joining us today on this last fall forum, and we are especially grateful to Dr. Hall for his wonderful presentation this morning.
Thank you, and happy Thanksgiving to all.
Thank you.
Thanks, Dr. Hall. Thank you. All
Thank
right, I'm shutting down the recording, and